Bismillahirrahmanirrahim. Today we will continue our lectures about Crohn's disease, and this is part 2. We will discuss how to assess the severity of Crohn's disease and also how to treat this disease. We have also some questions which need answers. We will also try to put them and find the answers in the literature. بسم الله الرحمن الرحيم. ربنا آتنا في الدنيا حسنة وفي الآخرة حسنة وقنا عذاب النار. Now we will come to the most important point in our plan of management is how to assess the severity of Crohn's disease, because we have a lot of drugs can be used for treatment of Crohn's disease. But the choice of these drugs, it depends on the severity from the start, mild severity, moderate severity, or high severity. And recently they have introduced the another item, which is the risk of complications. Okay, so we will use both assessment depending on the degree of the disease and the risk of the complications, including surgery and disability. Now we will begin with the scores. The first score, which is used in most studies, is this called Crohn's Disease Activity Index, CDAI. Okay, this score, if we look to it, it depends mainly on the symptoms of the patient, number of the liquid stool per day, the abdominal pain, general well-being, extraintestinal or physical complaints, antidiarrheal drugs, abdominal mass, hematocrit, body weight. Okay, if we look to all these parameters, you will find that they are mainly symptoms from the patient. These are questions you give them to the patient and you collect the answers from the patient. Also, each point has a weight in the score. You will find that the biggest weight here, it is given mainly to diarrhea. Okay, it is given mainly to diarrhea, which is a drawback in this score. By this score, we will classify the disease into 3 grades. Mild grade, in which the score is less than 150, moderate score, and severe score, in which is more than 450. Okay, so in the treatment plan, I will ask you from the start, severe or not severe. Okay, CDEI score more than 450 or less. Okay, this is to be easily understood. But nowadays this score, because it is depending mainly on the symptoms, its use is decreasing now in the recent literature. As we see that it was commonly used in the clinical trials, but its drawbacks that it needs answers from the patient, it depends on the symptoms of the patient, it gives a high weight to the diarrhea, we can't use it in patients who underwent resection. Another new point that when they did correlation between the CDAI and the endoscopy or calprotectin or the inflammatory markers like C-reactive protein and ESR, they found that there is poor correlation. Okay, this score you can easily calculate it through the Medcalc website or the Android or mobile application. Another score which is very simple compared to the CDEI score is called the Harvey-Bradshaw index. Also, if we look to it, you will find that it depends mainly on answers from the patient. Number 1, general well-being. Number 2, the abdominal pain. Number 3, abdominal masses. Okay, number of the liquid stool and extraintestinal manifestation. Also, this score is present on this mobile application. Okay, you will find that it is compared to the CDEI, It is easily to be calculated, but its drawback, it also gives a high weight to diarrhea, and it does not also correlate with the inflammatory markers like C-reactive protein, ESR, and calprotectin. Okay, active disease, it is a disease which is more than or equal 7. يبقى this is a score and this is a score which gives you a number. Through this number we can know that this is mild, moderate, or severe. Another score which depends mainly on endoscopy and it is also commonly used in the literature, it is called simple endoscopic score. Simple endoscopic score. This simple endoscopic score, SES, okay, it is a score which depends mainly on the size of the ulcer you see. If it is more than 2 centimeters, it is considered as large ulcer. The ulcerated surface related to the circumference of the intestine, if it is more than 30%, it is large ulcer. The affected area of the examined, for example, ileum, if it is more than 75 affection, it is large, okay? And if there is narrowing, if there is stricture, we have said previously that there are 3 types of strictures which may be inflammatory or fibrotic or malignant. So you try to pass the endoscope through it. So you must say if this structure is traversable with the endoscope or not. Okay. These parameters will be assessed in the ileum, in the right colon, in the transverse colon, in the left colon, in the rectum, and you will have a total score. Okay. It will give you also a number. The simple endoscopic score, SES, okay, SES, if it is more than or equal 16, it means severe disease. But mild disease 3 to 6, moderate disease 7 to 15, and inactive disease you may normal mucosa or trivial findings. So inactive score is considered when it is less than or equal to. Again, simple endoscopic score, it is very easy to be done and it can be used for assessment of the disease and confirmation of the remission. If it is less than 2, it will be the patient will be in a remission. There is another score which can be used by endoscopy. It is called the endoscopic index of severity, but in fact the simple endoscopic score is more commonly used. Also, if you see here, you will find that it depends on the presence of deep ulceration or superficial ulceration and surface involved by the disease in centimeters and so on. Okay. Also in it you will find that severe it will be more than or equal 12. Okay. After surgery, when you do resection for example, the terminal ileum, sometimes there is recurrence of the disease again. There is recurrence of the disease again, and you have to assess the recurrence. So the Rutgeerts score, it is used for assessment of the recurrence. If it is I0 or I1, okay, it is considered as remission. So remission it can be defined as no lesions in the terminal ileum or less than 5 abscess lesions. I2, I3, I4, they are active disease, more than 5 abscess lesions, okay? Diffuse abscess ileitis, diffuse inflammation, but okay, evaluation it is the endoscopic score of IO or I1 recurrence. It is an endoscopic score or I2 to I4. If the Rutgeerts score is commonly used to assess the post-A surgical recurrence of the disease. These are photos, okay, from this paper published in the gastroenterology. Here, there are no manifestations in the terminal ileum, it is normal. Here, you will find that there are abscess ulcers which are less than 5. Here, the number of the abscess ulcers increasing, cobblestone pattern, diffuse ulceration of the terminal ileum. Another score which can be used for assessment of the Crohn's disease, it depends on the imaging. It depends on the imaging, like the Crohn's disease MRI index. The radiologist can give you a score, and by this score you will find if the disease, if the disease is mild or moderate or severe. Okay, so the scores it can be number one clinical, depends on the symptoms of the patient, like the CDEI, okay, like the CDI score. number one, and it can be endoscopic, like the simple endoscopic score. Okay, it may be also like the Rutgeerts score, and it may be a radiological score like the Crohn's disease MRI index. There are other scores, I didn't put them. These other scores are based on the video capsule and so on, but no need. Sometimes, of course, these scores, when you look to their logs and items, maybe they bother you, but the internet now gives the rapid solution for every problem. So these are most common sites, and they have mobile applications. You can use them easily to calculate the score. We have the Italian group IPD score. Okay, the echo, you will find that on each page there are calculators. Okay, and of course we have the medical. So, collection from these scores, we can divide the CD activity into mild, moderate, severe, and fulminant, and of course, remission. In the mild score, the CDEI, it will be less than 150. If we use a simple endoscopic score, it will be 3 to 6. In the moderate, you will find the CDEI, it will be less than 450, and the endoscopic index, it will be less than 16, if you remember. Okay, this is a description which is found in the ECG, giving a description for the mild and the moderate without scores. Okay, mild cases, the patient are ambulatory and are eating and drinking normally, less than 10% weight loss, and there are no complications such as obstruction, fever, abdominal mass, dehydration. Maybe there is mild diarrhea and abdominal pain with trivial increase of the CRP. In the moderate case, you will find that there are cases who failed to respond to treatment. This is an item. Another item, there are more prominent symptoms like fever, significant weight loss, abdominal pain, tenderness, intermittent nausea, vomiting, and without obstructing findings or significant anemia. In the severe, your CDAI, it will be more than 450. Okay, simple endoscopic score SES will be more than 16. Okay, fulminant here, they have given a good description for them. They are patient, we have cachexia, significant weight loss, and positive complication, and they may need urgent hospitalization. Who are the patients who need urgent hospitalization? Number one, patient with persistent symptoms despite the introduction of conventional corticosteroid or biological agents. Number two, individuals presenting with high fever, persistent vomiting, evidence of intestinal obstruction, significant peritoneal signs, and they have endoscopic or radiological evidence of severe mucosal disease. Now we have learned that we can classify the activity of Crohn's disease into mild, moderate, and severe using mathematical scores. You will have a number. This number will translate into a degree of inflammation. Another method for assessment for the severity or of the severity of Crohn's disease is the risk assessment. Sometimes you calculate the CDAI score and you will find that it is mild. Okay, it is mild at the time of examination, but the patient have active complication like complex perianal fistula. Okay, like of course high output enterocutaneous fistula. The score is mild to moderate. Okay, but in fact, by your eye, you will find that there is active, significant, annoying problem. So another concept for assessment of Crohn's disease is the risk assessment, and we have said previously in the previous lecture that the patient with Crohn's disease is more liable for complications like strictures, gastrointestinal manifestations, penetration, fistulae, abdominal infections, and need for surgery, recurrence after surgery, and disability. How can I assess the risk? If we remember the Monterial classification we have said previously, by the items found in Monterial classification, you can assess the risk of the disease. We will use the age, the location and the extent of the disease, the presence of perianal disease, the behavior of the disease penetrating or not. We will add only two items, endoscopy and surgery. The AGA have the AGA Association, American Gastroenterology Association, has put a nice stratification for Crohn's disease. And the same items in the Montreal plus endoscopy and surgery were put, okay? We always, when you study any score, you should keep in your mind the high risk. If the parameters of high risk is not present, it is low risk, okay? Number one, age. If the disease is diagnosed less than 30 years of age, this is high risk person, okay? If the disease is extensive, for example, affecting more than 40 centimeters of the terminal ileum, it is significant disease and it is high risk disease. The presence of perianal disease or severe rectal inflammation is high risk patient, okay? The presence of penetration in the form of stricture or fistulae, okay, high risk patient. In endoscopy, the presence of deep ulcers more than 2 centimeters, it is high risk patient, okay? And of course, if the patient underwent prior surgery, he is high risk patient, okay? This is the simplest stratification system and I advise using it. There are other methods for stratification the risk of the disease. In the main issue of the Clinical Gastroenterology and Hepatology Journal, there is a nice paper called Positioning therapies in the management of Crohn's disease. They have classified the disease also into low risk disease and high risk disease, but they have increased parameters more than the AGA stratification system. Number one is there is a structural damage, large or deep ulcers, the presence of fistulae, prior intestinal resection, and the presence of strictures, okay? The inflammatory burden, if there is extensive disease more than 40 centimeters, okay? If there is high CRP, if there is low albumin, oh, he has added here some investigations like the low albumin and CRP, okay? The presence of a stoma, of course, this means that there is previous surgery. If the number of the stools is more than 10 per week, okay? If there is lack of response, PROs, to the biological therapy or immunosuppressive therapy, okay? If you have impact on the daily activity, if there are any rectal symptoms, the presence of anemia, daily abdominal weight, and there are emerging predictors like the high number and titer of the antimicrobial antibodies and the antimicrobial genetic peptide signature, okay? So this is a stratification system that can be used also, and it is recently published in the positioning therapies in the management of Crohn's disease in the clinical gastroenterology and hepatology. But from my point of view, the AGE classification is easier, okay, easier to memorize. Another score which is under research now, also published in the clinical gastroenterology, it is called the overall disease severity index, DCI, okay, of Crohn's disease. If we look to it carefully, you will find that this is an inverted pyramid. This is an inverted pyramid, okay? There he has both also the same items, the mucosal lesion. If there is normal mucosa, it will take a score of 0, okay? If there are large or deep mucosal lesions confirmed by MRI or endoscopy, it will assign 16 score, okay? Fistulae, perianal abscess, intestinal resection, stoma, disease extent, frequency of loose stool, okay? Presence of stricture, CRP, biological use, albumin, anorectal symptoms, anemia. So he has included all the parameters said in the previous slide, and it is called now the overall disease severity index. Again, because The assessment of the risk is now under focus in research. A new program was was designed to assess the risk, and it is called the Personalized Risk and Outcome Prediction Tool Prospect. Okay, this is a computer program in which you will put data, and these data, okay, will be translated into high risk or low risk patient within 3 years. Within 3 years, okay. If we look to these are screens from the program, I will put the data. He is male or female, birth date, date of diagnosis, okay, to know the time of diagnosis of the disease. If there are upper GIT tract, small bowel, small colon, right colon, for example, transverse colon, left colon, perianal, it is the location of the disease. He has added some antibodies like ASCA, okay, and some antibodies like ANCA and the anti-E. coli antibody. And also, if there is NOD2 variant, you remember that this gene was associated with the presence of aggressive disease and penetrating disease. Also, he has both these data. Okay, he will calculate. Now we have two output. This patient, the program gives you a graph and says to, by the progress of the time within the next 3 years, the risk of complications are markedly increasing. So he is considered as high risk patient. In this screen, the opposite is seen. This patient is low risk patient. So the program is very useful for us and it can predict the outcome within the next 3 years. I hope to be commercially found soon. We will come now to another point. You say now that we will stratify the disease into low risk or high risk. This is before operation, okay? What's about after operation? They found that at operation, if the patient has penetrating disease, multiple fistulae, okay, or he has underwent more than 2 intestinal resections, previous intestinal resection, if there is active smoking, if there is long disease, for example, or short disease, you should calculate it. Short disease and surgery is more aggressive disease, okay? If these are findings that are associated with high risk patient for recurrence of the disease. If we look here, that high risk patient, this is another method for calculation. If he is young age less than 30, if he is active smoker, if there is more than or equal to prior surgeries for penetrating disease with or without perianal disease, you will find that the clinical recurrence within 18 months after surgery is 15% and within 1.5 years is 80%. Okay. This we have put this slide in the previous lecture. They are collections of the annoying scores or annoying investigation which alarm us that this patient is considered as high risk patient. So from all these slides we can understand that there are two methods for assessment of the disease activity. The first method is using mathematical scores. They will give you a number that will be translated into a degree like mild, moderate, and severe, and they can be calculated using our mobile applications, okay, or internet. And we have another stratification system for the risk, like high risk or low risk, okay. These scores and these risk stratifications will guide us in the treatment. Later on, we will discuss how. Okay. What are the drugs that are used? What are the drugs used in the treatment of CD disease? Of NCD. We have 5 ASA like mesalamine, steroids, prednisolone, cyclopurines like azathioprine, anti-TNF like infliximab and adalimumab, and integrin like vedolizumab, and interleukin like ustekinumab. Okay, these are the commonly drugs used in the treatment of Crohn's disease. What are the concepts of treatment? Remember, there is no definitive treatment for Crohn's disease because the etiology is unknown. So most drugs, they try to stop or slow down the inflammation. The concepts of treatment are: number one, induction of remission, maintenance of remission, prevention and treatment of medication-related side effects, prevention and treatment of nutritional deficiencies, prevention of infectious complications, especially if there is Crohn's colitis, and prevention and treatment of other complications like fistulae and so on. The new concept of treatment is treat to target. Is treat to target. You will set a plan in the treatment, okay? This is your target. And you will reassess yourself if you have achieved the target or not, okay? If I did not achieve the target, I have to revise why. Is it wrong diagnosis from the start? Or there is poor compliance from the patient? Or I used the wrong drug and I need to switch to another drug group, okay? So, the first step in the treatment, this is a good figure of course from the Lancet. I will assess Crohn's disease activity by scores or risk stratification system, okay? If I have mild disease, it will be treated by budesonide or systemic steroids. We will discuss later. Moderate disease, it will need steroids plus immunomodulator. If it is severe disease, it will need biologicals, okay? This is my target, okay? My target is giving any of these drugs and I achieve remission, okay? I will reassess myself again and I will assess the patient using the inflammatory markers like CRP, fecal calprotectin, and I will do follow-up endoscopy or imaging like MRI to avoid radiation. If there is still inflammation, the first thing you should do is to check the compliance of the patient. If the patient compliant or not. If the patient is compliant, there is something wrong in my plan. I need to do dose optimization or I need to add immunosuppressant like azathioprine. I need to switch the drug group from anti-TNF to anti-integrin like Vido, okay? These are, if I achieve this, I will monitor the inflammatory markers again. If they have decreased, I did tight monitoring of the disease and I have achieved my target. Okay? What is the definition of remission? The Canadian Association of Gastroenterology, CG, have put criteria for remission in Crohn's disease patients. Okay? The Canadian Association said that remission is defined as symptomatic plus either endoscopic remission or radiological remission. Again, remission, it is symptomatic remission plus either endoscopic or radiological remission. Symptomatic remission, all the symptoms related to Crohn's disease have disappeared. Okay? Endoscopically, there are no ulcerations. Okay? If you remember the simple endoscopic score, it will be less than 2. Okay? Or the radiological remission, in which there is absence of detectable disease activity on CT enterography, MRI enterography, or small bowel ultrasonography. If you could not achieve this, we will shift to another target, which is called symptomatic response, in which it is meaningful improvement in the symptoms as judged by both the patient and the physician in the absence of remission, and the response should not be considered as a desirable final outcome, but it is useful to assess early efficacy of the treatment. When we study the drugs which are used in the treatment of Crohn's disease, we will find that there are some drugs which are used in the treatment of ulcerative colitis are not effective in Crohn's disease. Mesalamine is not effective drug in Crohn's disease. Forget it. Okay? If you have perianal disease or perianal fistula, forget mesalamine and forget corticosteroid. They have no role, and corticosteroid may increase the infection of the fistulae. Okay? When we come to the biological therapy anti-TNF, we have adalimumab, we have infliximab. Okay? They are licensed in America and Europe. But certolizumab Bigol, it is not licensed in Canada and it is not licensed in Europe. Okay? If we have perianal fistula, we should ask ourselves, is it simple or complex? If it is simple and asymptomatic, there are no discharge from it, there is no treatment, simply. If it is symptomatic, there is discharge from it, look to the inflammation of the rectum. If there is rectal inflammation, we will behave with it as if it is complex perianal fistula. If there is no rectal inflammation, it will need only just non-cutting ceton or fistulotomy. Okay, this slide is very important. Again, mesalamine have no role in the treatment of Crohn's disease. Corticosteroid and 5-ASA have no role in the treatment of perianal fistula. Certolizumab is not used in Canada and in Europe. Okay? Fistula, we should classify it into simple or complex. If it is simple and asymptomatic, no treatment. If it is symptomatic simple, look to the rectum. If it is inflamed, we will consider it complex. If there is no rectal inflammation, just ceton or fistulotomy. Okay? Of course, the complex perianal fistula, it will need antibiotics, anti-TNF, and surgery. The anterior cutaneous fistula, when you treat it, okay, if it is low output, minimal discharge, you will use anti-TNF plus azathioprine, okay. If it is high output, surgery will be needed. Anterior enteric fistula are commonly asymptomatic and no treatment. If there is rectovaginal fistula, we will need anti-TNF and azathioprine plus surgery. Anterovesical or colovesical fistula, you will need anti-TNF plus surgery. Any fistula in the pelvis, with other organ in the pelvis, surgery plus medical therapy are needed. Of course, remission in perianal disease, we have Toronto criteria, okay? Toronto said that to say complete remission, we must have symptomatic and radiological. Of course, we don't use endoscopy for assessment of fistula, okay? Symptomatic, no discharge, and radiological, it is absence of inflammation in the fistula tract and there is no abscesses, okay? These slides are pavement for understanding how the guidelines recommend. Now we will come to another point. What do the guidelines recommend, and is there is conflict in the guideline or not? People are gathering, expert people. They will give you recommendations, but if we compare the guidelines, you will have sometimes a puzzle and confusion. I have gathered data from these guidelines. The American Gastroenterology Association Institute Guideline AGA on the management of Crohn's disease after surgical resection, Clinical Practice Guideline for the medical management of perianal fistulizing Crohn's disease, Toronto Consensus, the ECG Clinical Guideline Management of Crohn's disease, the British Society of Gastroenterology Consensus Guidelines for Management of Inflammatory Bowel Disease, the Canadian Association of Gastroenterology Clinical Practice Guideline for the Management of Luminal Crohn's disease, practice guidelines on the endoscopic treatment of Crohn's disease strictures, a consensus statement from the Global Intervention Inflammatory Bowel Disease, okay, global interventional inflammatory bowel disease group, the eco guideline, medical treatment, and eco guidelines, surgical treatment. Uh, I have gathered the final recommendations for each guideline. Sometimes you find that there is a description of the disease and they did not give final conclusion, so I will not put it. Number one, the diagnosis of Crohn's disease. The ECG has recommended the following. Number one, fecal calprotectin can differentiate IBS, irritable bowel syndrome, from IBD. This is the first guideline which used fecal calprotectin. It is against genetic testing. Okay, don't do genetic study to diagnose Crohn's disease. But of course, if the prospect program used for stratification is used worldwide, we will need to do genetic testing. Against histological markers like ASCA, ASCCA, okay, you must do ileocolonoscopy plus biopsies. The BSG, British Society of Gastroenterology, also recommended ileocolonoscopy plus biopsies. Biopsies must be taken from normal and abnormal mucosa because normal mucosa may have active histological disease. Okay? The ECG also said before you begin a treatment, you should have a map of the disease, full map of the disease. The disease is confined to the ileum, to the colon, upper GIT, for example. Okay, what is the extent of the disease? Okay, if there is abnormal behavior, fistulization or stricturing, you should have before treatment a map. Okay. Also, the ECG and BCG have recommended biopsies from normal mucosa and abnormal mucosa. Also, they said that do only EGD if there is upper GIT symptoms because the percentage of upper GIT infection in Crohn's disease is low. So this is a don't waste your time and your money. Use video capsule endoscopy if you have suspicious Crohn's disease, but the BSG has added a nice point that if you are suspecting a stricture or obstruction, you should use patency capsule first. If you remember, a patency capsule is a capsule which can disintegrate after a certain period of time. So if there is obstruction or infection of the capsule, it will disintegrate and no problem will occur to the patient. If you remember in the previous lecture, we have said, usually, if the patient has symptoms suggestive of obstruction like nausea and repeated vomiting, you avoid the capsule, but if there is no obstructing symptoms, you can use the capsule safety, but the BSG had recommended using a patency capsule, okay? Deep enteroscopy is not a routine diagnostic testing in Crohn's disease. Screening for dysplasia. Okay, these slides are very important because the ECG is the only one who had addressed this point. If you remember in ulcerative colitis, we have said before that the ECG has recommended using either chromoendoscopy or narrowband imaging. In Crohn's colitis, she is against narrowband imaging. In the diagnosis also, CT interrography and MRI interrography, they are equal, okay? But due to the concern of radiation with CTE, okay, the ECG has recommended that the MRE is preferred in patients less than 35 years old or needing repeated imaging. BSG, they are the same, okay? Of course, the Toronto and ECG and BCG said, and Toronto and ECG said, if you are suspecting perianal disease, you should do basically pelvic MRI, fistulogram, plus or with or without EUS if it is available to accurately assess the perianal disease. The ECG always love to do mapping before therapy, so IBD type, location, and disease activity should be documented. How to measure the disease activity? Did some guidelines use a score? Some guidelines use the score and some guidelines use stratification system. The ECG have used CDAI, okay, and SES, simple endoscopic score, okay, we have previously said. The Canadian Association preferred risk stratification. The Canadian Association preferred risk stratification more than scores. Disease modifiers, okay. There are some modifiers, if we avoid them, or there are some things that if we avoid them, we will improve our disease. If we avoid NSAIDs, the activity will decrease. Avoid smoking is mandatory, especially if the patient underwent surgery. Don't restrict antibiotics, okay? Always try to treat psychiatric element because the symptoms which come from the patient may be psychiatric or psychological. If we don't give a strong treatment, most patients will proceed to surgery. How I monitor the disease? ECG is the only one who gives this parameter. You can monitor the disease using fecal calprotectin and fecal lactoferrin. You may use CRP, CTE or MRE, and endoscopy. Okay, monitoring activity, the ECG is the only one who had give recommendations. Fecal calprotectin, as we know, we will measure it. Okay, if the fecal calprotectin on treatment is still high, it means that the patient is not compliant with the treatment, okay, or there is failure of response to the treatment and you have to change them, okay, and in such a situation you should do endoscopy to be assured that there is severe disease and loss of response to therapy, okay. Fecal calprotectin also in a patient with no symptoms now, if it is high and the patient is asymptomatic in treatment, consider that there will be flare in the coming months or there will be relapse, okay? Complication may occur without therapeutic change, okay? And consider morphological assessment also with endoscopy or MRI to optimize or change your therapy. So fecal calprotectin is useful. Now we will come to the biologicals, okay? These are the biological drugs used in the treatment of UC and CD, okay? Because Crohn's disease is aggressive disease, you will find that these drugs were licensed for Crohn's disease always before ulcerative colitis. Look here, infliximab, look here. The golimumab is licensed only for ulcerative colitis. Meanwhile, the sertolizumab is licensed only for Crohn's disease, but in America only. Okay. Now we have a question. If you give a drug, whatever this drug, when you will assess the response? The ECG said that you should assess the response within 12 to 16 weeks. Okay. The Canadian Association gave detailed description for the follow-up for each drug. If you give sulfasalazine for Crohn's colitis, reassessment after 2 to 4 months. If you are using budesonide, 4 to 8 weeks. If you are using steroids, 2 to 4 weeks. If you are using IV inside prednisolone, 1 week. If you are using anti-TNF, 8 to 12 weeks. If you are using Vido, up to 14 weeks. If you are using ustekinumab, up to 10 weeks. The other guidelines did not mention this point. Now we will come to the first step in the treatment of Crohn's disease is risk stratification and disease activity. The first situation is mild to moderate active disease. If you are using CDAI, it is less than 450. or the SES less than 16. Okay. Low risk patient older than 30 years. Okay. Localized disease less than 40 centimeters of the terminal ileum. There is no stricture, there is no perianal fistula, there is no interior fistula, and also there is no prior history of surgery. Okay. The disease, it may affect the colon, and we will call it Crohn's colitis, and it may affect the terminal ileum. Okay. If the drugs which can be used, 5-ASA like mesalamine, sulfasalazine, antibiotics, the budesonide, and the conventional steroids like prednisolone, diet, and surgery. These are the commonly used drugs in the treatment. Okay. For mild to moderate active disease, let's go to the guidelines and see who is with and who is against. Number one, all the guidelines ECG, BCG, CEG, and ECHO said one word: against oral mesalamine because they are useless in Crohn's disease treatments, whether intestinal type or colic type. Okay? Okay. In the past, they were treating Crohn's disease with antibiotics like ciprofloxacin, metronidazole, and sometimes with antimycobacterial drugs like TB. The guidelines now say avoid antibiotics in the treatment of Crohn's disease. Okay? Against oral metronidazole, against oral ciprofloxacin, against antimycobacterial therapy. This is the ECG. And also the CEG said the same, avoid metronidazole and avoid ciprofloxacin. Mesalamine, avoid. Antibiotics, also avoid them. Okay, we will come to the other parameter, which is steroid. Sulfasalazine, sometimes the patient may come with isolated Crohn's colitis. We have said that mesalamines are not effective, but they found that sulfasalazine is effective in mild Crohn's colitis. Sulfasalazine is effective in mild Crohn's colitis. The ECG said that, but its effect is weak. Its effect is weak, so it is not used for maintenance. You will find that in Crohn's disease, we don't use sulfasalazine as a maintenance drug. So, in Crohn's colitis, you can use sulfasalazine 3 to 6 grams. The CAG said also you can use it for from 4 to 6 grams. Okay. The BCG did not recommend sulfasalazine, and the ECHO did not recommend sulfasalazine. Okay, because it is a weak drug. The CAG said that if sulfasalazine did not bring a response, shift to steroids. Okay. Okay. If I don't use sulfasalazine or I don't recommend sulfasalazine, how I will treat Crohn's colitis? The only one who wrote recommendation is the BSG and said that you should use corticosteroids like prednisolone for 8 weeks. Okay? So, till now, we don't have strong recommendations in the treatment of Crohn's colitis. Because sulfasalazine is weak, some guidelines have recommended them for induction, not for maintenance. Okay? And the British Society of Gastroenterology avoided sulfasalazine and recommended from the start corticosteroids. Okay? Suppose that the disease is localized to the ileocecal region. Suppose that the disease is localized to the ileocecal region. All guidelines recommended one drug, budesonide 9 milligram here, as we see here. يبقى all drugs recommended ileocecal CDE, ileocecal CD. They have recommended budesonide for they recommended budesonide 8 milligrams once daily for 2 months or 3 months. Okay? Type. Which type of budesonide we should use? If you remember in the UC lecture, we have said that we have two types of budesonide. The conventional budesonide, which releases its drug in the ileocecal region, and the budesonide multimatrix, the new one, which releases its drug in the terminal ileum and whole colon. The BSG said in its recommendations that there are no trials for the budesonide MMX, so don't use. Okay? Suppose that the Crohn's disease is present in the intestine. It is not localized to the terminal ileum. How should we give treatment? Of course, here in the CG said if there is failure of the budesonide, this is a very important question. If I give budesonide and there is no response, she said there is no recommendations with or against oral prednisolone. If you want to give oral prednisolone, give. If you want to switch to biological therapy, switch. There is no strong recommendation. Okay. The British Society of Gastroenterology said any Crohn's disease, whatever the site, colon or intestine, always use oral steroids as long as it is mild disease or low risk disease. Okay? The BCG gave another point. In pediatric patient, if the mother does not want to give her baby or her child drugs, you may try what is called exclusive intranutrition. It is a type of nutrition which may cause remission in patients with Crohn's disease, especially in the children, but the Canadian Association was against this. The BSG said also, if the disease is localized to the ileocecal region, okay, if you remember in the natural history, we have said that most patients with Crohn's disease, in 85% of the cases, you will have confined disease, not extending disease. Okay, so the BSG recommended that if there is ileocecal disease and the patient does not want medical therapy, you can do resection for him. This is a nice algorithm from the Canadian guidelines, CG. It said, if you have mild to moderate disease by scores, by whatever the score you use, okay? Ask yourself, where is the site of the disease? In the colon or in the terminal ileum, intestine and the colon? If the disease is confined to the colon, you should use either, look to this asterisk, you can use either sulfasalazine, this weak drug, or you can use corticosteroids. Okay? The British Society said use corticosteroids from the start because it is stronger than sulfasalazine. This is the same in this algorithm. Okay? Assess the response after 4 weeks. If there is remission, taper corticosteroids, of course, and add immunomodulator. But if there is no response for corticosteroids in the colon, okay, you should shift this patient to moderate to severe algorithm. Okay? If the disease in the terminal ileum, all the guidelines said one way budesonide 9 milligram for 2 months. I will ask myself if there is response or not. If there is good response, I will taper it because budesonide is not used for maintenance. And if there is no response, I will shift to oral corticosteroid or other drug regimen. Easy? Also here, this is a new paper published in the Clinical Gastroenterology and Hepatology, positioning therapy in the management of Crohn's disease. This is the algorithm also, it is the same. Number one, I will do complete evaluation for the patient to find if he is high risk or low risk, okay? High risk patient, we know its criteria and low risk, okay? the disease is mild to moderate, okay, and at the same time low risk. If it is confined to the ileocecal region, I will give budesonide. If it is in the colon, I will give either prednisolone or the weak drug sulfasalazine. We said the sulfasalazine was recommended by the ECG and the CEG, okay? If there is remission, yes. No maintenance therapy for sulfasalazine or budesonide. I will just monitor the patient by CRP, fecal calprotectin, and endoscopic evaluation. If there is no response, okay, I will re-evaluate the disease. If it is high burden or low burden, you will predict that he will enter in complication. I will consider him as a high risk patient. If it is low risk, I will search for another symptoms or other cause for the manifestation. If we have if we face a patient with moderate to severe active disease, or he is high risk patient from the start, we will use steroids, immunomodulators, anti-TNF, anti-integrin, anti-interleukin, surgery, and alternative therapy. Let's go to the guidelines and see what they recommend. Number one, there was a treatment used in the past called leukocyte apheresis. Okay, BCG said avoid. Okay, rectal corticosteroids have no role, and rectal steroid have no role in the treatment of Crohn's colitis. Okay. All the guidelines said that you can give corticosteroids for the treatment of moderate to severe Crohn's disease, okay? Like prednisolone, and then you should do tapering, okay? But never give steroids if there is perianal disease because they increase the risk of fistula and abscess formation, okay? And also they said that the steroids, they have no effect on the healing and they have no effect on the maintenance, okay? So we can give the first drug which can be used in the treatment of moderate to severe Crohn's disease is oral corticosteroids. In the past, before the era of the biological therapy, they used the immunomodulators induction, but nowadays avoid, never give immunomodulator like azacitidine for induction, okay, except in poor countries, of course. We give immunomodulator, we can give them with the anti-TNF to decrease the immunogenicity, the anti-drug antibody, this is very important, or we can use them for maintenance only. But the ECG has recommended to measure the TPMT before giving the drug to avoid drastic leukopenia, okay? Also, methotrexate, the same like azacitidine, never used for induction. It can be given for maintenance of remission, or it can be given for prevention of immunogenicity or formation of anti-drug antibodies. Usually, we use no drugs from 15 or 12 to 25 IV, IM, or subcutaneously every week. The most powerful drug used for treatment of moderate to severe disease. Number one, we said corticosteroid. The most important is biological therapy. The question is, should I use biological therapy after failure of corticosteroids, or should I use them de novo from the start? Okay, there is conflict and debate between the guidelines. The ECG said if there is failure for corticosteroids or thioprines induction, switch to biological therapy, and remember the certolizumab is not approved in Canada or Europe. Okay? In Canada, failed steroid switch to anti-TNF, failed steroid in echo switch to anti-TNF. Okay? But the British Society and the Canadian Society both said from the start, Assess the severity of the disease by a score, CDAI, said it is moderate to severe. Then do stratification for the disease. Is it high risk disease or low risk disease? If you find it from the start high risk, here you can start from the start de novo anti-TNF. So BSG high risk patient, we can use de novo induction with anti-TNF, the same in the CEG, the same. And they said if you use anti-TNF in treatment of Crohn's disease, you must combine it with azathioprine. Okay, you must combine it with azathioprine to decrease the antibody or anti-drug formation. The British Society is the only one who said you can use either azathioprine or methotrexate, but the ECG and the CAG and the ECHO, CEG and the ECHO, they recommended only azathioprine. Okay. The ECG said that you can use also biosimilars from the start. ECHO guidelines has added a recommendation on the surgery if the patient does not recommend medical treatment. He said laparoscopic resection in patient with limited non-structural ileocecal disease, okay, it can be used if the patient does not want. Yani you did calculation for the disease, you found that it is disease localized to the ileocecal region, moderate to severe, but it is not high risk, it is low risk, okay, from the criteria previously said. Here you can do surgery if the patient wants to avoid medical therapy. Okay. The CAG said, what will occur if you have failure of anti-TNF therapy? They gave option if you have failed anti-TNF is to do dose intensification or decreasing the duration between doses to achieve the response. It did not recommend reactive therapeutic drug monitoring, TDM. We will discuss it later. The choice, now we will check to another group, which is anti-integrin, vedolizumab and natalizumab. The guidelines said if there is failed steroid therapy, which we will shift to anti-TNF. But the CAG and the ECHO said you can shift also to vedolizumab. Of course, if there is failure of anti-TNF, we can shift to vedolizumab. Okay? طيب, should we combine vedolizumab with immunomodulator? CCEG did not give clear recommendation with or against. Should we use de novo vedolizumab from the start? Yes. If he is high risk patient, you can use them from the start. The ECG recommended de novo vedolizumab, but with or without azathioprine. The same in the British Society. What will we do if we have failed vedolizumab? There is no recommendation with or against switching to ustekinumab, the last one. The only guidelines who had recommended natalizumab is the ECG, but you should test for the GC virus first. If it is negative at baseline and follow up with drug, you can give natalizumab, okay? But the other guidelines did not mention natalizumab, all recommended vedolizumab. So, vedolizumab, it can be used as a salvage drug if we have failed steroid therapy or anti-TNF therapy. We can use it de novo drug from the start, especially in high risk group. The same with ustekinumab, failed steroid, failed anti-TNF, failed thioprines. We can shift the patient to ustekinumab, and we can use them from the start, especially in high risk group. Okay. Should we combine it with immunomodulator? Till now there is debate, so there is no obvious recommendation with or against in the CEG. This is a bad scenario put here. If we have failed ustekinumab, provided that the patient did not use vedolizumab from the start, should we switch him to vedolizumab? There is no clear recommendation. Alternative therapy, the ECG did not recommend using cyclosporin, mycophenolate, mofetil, and tacrolimus in the treatment. The CAG had put this recommendation against probiotics, against omega-3, against marijuana for induction, against naltrexone for induction. This is a slide on the alternative therapy. This is a nice algorithm from the CEG set, and really it is very useful. Assess the disease from the start. It is moderate to severe by the scores. Then assess the severity. If the patient is high risk from the start, you can use biological therapy plus thiopurine or methotrexate, or you can use, if they are not available, corticosteroids. Okay? If it is low risk, use number one corticosteroid. If the patient entered in remission, we will do tapering for steroids and continue on thiopurines as maintenance. If the patient did not respond, here I can shift him to anti-TNF or to vedolizumab or to ustekinumab. Okay. If the patient we used in the high risk group, we used the anti-TNF, and there is bad response, you should know what is the cause. So we need to optimization of the therapy, or we need to shift to another group. Also, this is a nice algorithm from the positioning therapy in the management of Crohn's disease, published in the clinical gastroenterology. The same. We should assess the degree of the disease mild to moderate by scores. Then you have to clarify the stratification system. Is it high risk or low risk? If it is high risk from the start, I will use biological therapy, infliximab or adalimumab, with or without corticosteroid, of course, with or without thiopurines, but of course with thiopurines, as most guidelines recommend. Infliximab is better than adalimumab, and combination therapy with azacitidine is better than monotherapy. If there is failure or contraindication for anti-TNF from the start, we can use ustekinumab. Okay. Also, the second drug in patient with if there is failure to anti-TNF, we can shift the patient to ustekinumab with or without thiopurines. Okay. And this is if there is moderate disease and disease severity and higher disease severity. If there is risk averse, okay, if there is contraindication, suppose that you have a situation in which there is contraindication for anti-TNF because there is prior malignancy, especially lymphoma, or there is serious infection, okay, or there are other conditions that may prevent the using of anti-TNF, like heart failure, for example. Even here we can use, if the disease is moderate, you can use vedolizumab. Then, if it failed, we can use ustekinumab. If the disease is severe from the start, it's better to use ustekinumab from the start. This is very important slide. Especially, it is the first one who give recommendation on cases with contraindicated anti-TNF. Okay. If we have fulminant disease which requires admission, especially with Crohn's colitis, we should use, like you see, we will use corticosteroid, and second line is infliximab. Maintenance. Regarding the maintenance, of course, we said that there is no role for corticosteroid in the maintenance. 5-ASA are not recommended for maintenance. Steroids are not recommended for maintenance. Thiopurines can be used if you used steroid induction. Okay. If we used anti-TNF induction, we should continue the same agent. Okay. But the ECO guidelines recommended other interesting points. Suppose that the patient now is in long-term remission using anti-TNF and azathioprine, and we know that there is accusation of the azathioprine in the formation of lymphoma. So the echo said that if the patient is in long-term remission, especially more than 2 years, you may stop azathioprine, but of course you should discuss with the patient first. But suppose that the patient now is on long-term remission on anti-TNF, the echo guidelines did not put recommendation with or against stopping the anti-TNF. So till now, if you begin anti-TNF, you will continue for life. Vedolizumab, of course, continue vedolizumab, and of course, in the echo, we will come to a very important point is the therapeutic drug monitoring. Should we test the drug level in the blood to know it lost the efficacy or not? The only one who discusses this point is the CEG and ECHO. CEG said if there is only loss of response during therapy, you may use TDM to decide the plan. But the echo is not with or against reactive TDM. Okay? The only one who recommended reactive TDM is the CEG, but echo not with or against. Other guidelines did not mention this point. Of course, Stellara, we will continue maintenance. We have said that if you have a patient with disease, we will stratify the patient using the score and the stratification system previously said, like the prospect and so on. So we will have mild to moderate disease, low risk, and moderate to severe with high risk. Now we will come to a very important issue is how to treat perianal fistula. Perianal fistula, if you find it from the start in a patient with Crohn's disease, it will need a different algorithm for treatment. These are the drugs that were commonly used in the treatment of perianal fistula: steroids, immunomodulators, anti-TNF, anti-integrin, anti-interleukin, antibiotics, ceton or abscess drainage, surgery, and alternative therapy. If you face a patient with perianal disease in your clinic from the start, there is a point of conflict in the guidelines, or it is not clear in the guidelines. We know in the slide put in the treatment that we have classified perianal fistula into two types: simple and complex. Simple, below the dentate line, single tract, external opening near the anus. Okay? And the complex type, the inner opening above the dentate line, it may have multiple tracts and multiple openings in the buttocks. The first thing, if it is simple and no discharge, no treatment. If it is simple and have discharge, look for the rectum. Severe rectal inflammation, treat it as if it is complex fistula. No rectal inflammation, just post ceton. The guidelines wrote frank complex perianal fistula for as indication for anti-TNF therapy, and there are guidelines which wrote any anal fistula is a recommendation for anti-TNF therapy. But in the discussion, you will find that they mean complex perianal fistula, but in the recommendation they did not write the word complex perianal fistula, so it is conflict for us. If you have a case of perianal fistula, the first question you should ask yourself is there is associated infection or abscess or not. Never give medical treatment for perianal perianal fistula if there is infection, because all the infections, all the medical therapies will increase the infection. Okay, so when you have a case with fistulizing disease, number one, I will consult the surgeon for co-management. Co-management, okay? I should do assessment for the fistula using examination under anesthesia and also using pelvic MRI with or without EUS. If there is abscess, it must be treated before medical therapy. If the abscess is less than 5 millimeters, it is usually treated with antibiotics, but if the abscess is large, usually we need surgical drainage or radiological drainage. What are the medical drugs that were used in the treatment? The only medical drug now, which is approved for treatment of perianal fistula is infliximab number 1, then adalimumab. These are the only two drugs approved for the treatment nowadays for the treatment of perianal fistula. I will give anti-TNF Toronto. I will give anti-TNF plus azacitidine or methotrexate to induce remission. In the past, they used azacitidine for induction of remission before the era of biological therapy. And also remember, they did not find efficacy for the mesalamine or corticosteroid for treatment of fistula. So we have weak drug which is thiopurines for induction, and nowadays all the guidelines are against. This is nonsense nowadays. We can use only anti-TNF. The anti-TNF approved is infliximab, then adalimumab. What is about Vido and what is about ustekinumab? There is no strong studies, and most recommendation for the use is experimental from post hoc analysis. Okay? When you give infliximab, it is better to combine it with azacitidine because it will decrease the immunogenicity. This is number one. And number two, azacitidine in the past was used in the induction of remission. So, Toronto, I will give anti-TNF plus azacitidine. ECG infliximab is effective in the treatment of perianal fistula, anterior-cutaneous fistula, and rectovaginal fistula. And adalimumab is a second line. The BSG said infliximab is the only drug approved as number one. ECHO said number one use infliximab, but ECHO and British guidelines, in fact, the ECHO and the British guidelines, they wrote frankly complex perianal fistula. It is against thiopurine monotherapy for fistula closure, the old therapy. Okay. The ECHO did not say that there is sufficient evidence to add azacitidine for induction, not to decrease immunogenicity. But of course, you must combine them from the start. The British Society said it is better when you give infliximab to measure the drug level and to make your target above 10. Okay, it is better. It is better, but it is not a recommendation. So, till now, the recommendations in the treatment of perianal fistula is to using the conventional dosing system, 5 mg per kg, not 10 mg per kg. But the British Society is the only one who focused in this, that if you elevate the trough level of the infliximab to 10, you may have better healing, but it is not a recommendation. because it increases the cost. And there are some studies which did not find the difference between the two doses. ECG said also, if you don't have infliximab, you may use tacrolimus for short duration, okay? But ECHO said that the evidence for Vido and ustekinumab is not sufficient now. What is about antibiotics? We will discuss here antibiotics as induction therapy. In the past, they used antibiotics for treatment of Crohn's disease, and we said that nowadays we are against. Also, in the past, they used antibiotics for induction of closure of the fistula. Okay? Should we use them or not? For induction of closure, not for treatment of infection. If there is infection, we will use them. But if there is no infection, Toronto guidelines said any patient with fistulizing disease, number one, use antibiotics. Toronto said you should use antibiotics. ECG said that antibiotics may be effective in treating especially simple perianal fistula. Of course, we can use metronidazole, ciprofloxacin, and levofloxacin, but nowadays they don't prefer ciprofloxacin or levo to avoid tendon Achilles cutting or dysfunction. But they recommended metronidazole for 4 to 8 weeks, 1 or 2 months. But if the perianal fistula is complex type, they don't have any benefit except of improving the symptoms. The ECHO guidelines said that if it is complex perianal fistula, never use antibiotics. So, if we try to gather all these gather all these guidelines, we can say, if the fistula is simple, we may use antibiotics, but if it is complex, antibiotics are useless, or at least they may improve the symptoms. Infliximab, when you give infliximab, should we give it alone or with azathioprine or with what? The ECG said that because we say that antibiotics may be effective, it is better to combine infliximab with antibiotics, because they found that combination between infliximab and antibiotics more effective than infliximab alone. So you can combine infliximab with azathioprine or with antibiotics. And also they said, if we combine infliximab with ceton placement for drainage of the fistula, is better than infliximab alone. The British Society of Gastroenterology said it is better to combine infliximab and ceton from the start. Okay, of course, never start antibiotics before drainage of any abscess surgically or radiologically. Okay, if the patient responded, we will continue infliximab. Okay, if the patient failed, we will need surgery. What are the surgeries which can be done in a patient with complex perianal fistula? It was heavily addressed by the ECHO guidelines. The ECHO guidelines said that using the surgery, we can use what is called advancement flaps is a good option. There is another option which is called fibrin glue injection into the fistula, but it is of limited efficacy, not effective as advancement flaps. And also the ligation of the intrasphincteric fistula tract is an option, the ECHO said, if you want to avoid surgery. We can, if you want to avoid the advancement of relapse, we can use either the injection of glue or ligation of intrasphincteric fistula. The ECHO guidelines said also that don't use what is called anal fistula plugs because abscess may form. If the patient supports that the patient did not respond to any therapy, even surgery. You did the surgery, like flaps, and there is no response. The British Society said in such a case, we can do what is called fecal stream diversion, in any case refractory to medical treatment or severe disease, but the reversion of the anatomy will not be easy. The ECHO guidelines said that you can try other types of therapy like stem cell therapy, allogenic adipose derived stem cell therapy, okay? And also they said that if there is no response to medical and surgical therapy, you can use diverting stoma. This is the last line, and we always try to avoid it because reversal of anatomy is difficult. Toronto consensus, this is a good algorithm from the Toronto consensus. I will assess the activity of the area of the perianal fistula. If there is infection from the start, pain, fever, infection, we should do drainage for the abscess and ceton placement. If there is no evidence of infection, we can give antibiotics alone. If you remember that the only one who recommended antibiotics were the Toronto, ECG said may use, other guidelines were against, okay? If there is no response, we will use anti-TNF plus thiopurines. The ECG said anti-TNF plus ceton, anti-TNF plus antibiotics. If there is response, we will continue on the same. If there is no response on anti-TNF plus thiopurines, okay, we can do fistula plug, echo against. We can use the diversion. We can do proctectomy. Okay, this is another slide from the Monday night IBD. This is very nice. I will do examination for the presence of perianal disease. If it is symptomatic, we must do surgical evaluation. We will do MRI pelvis to see if it is simple fistula or complex fistula. We will use infliximab, okay, and we will try to monitor our patient, okay. We have a perianal fistula. If there is no abscess on examination, we can use only antibiotics for induction. If there is abscess on MRI, we must use antibiotics, plus we must do drainage of the abscess and ceton placement. If the fistula is simple, confined to the anal canal, it can heal with antibiotics like Cipro and metronidazole, or fistulotomy if there is no rectal inflammation. If the fistula is complex from the start, we will use ceton and we will need infliximab, okay? In the simple one, infliximab will be used if there is proctitis, as we have said before, because we will consider it as if it is complex. We will use thiopurines, okay, to prevent anti-drug antibodies. We will use antibiotics during the induction, especially if there is no ceton to avoid infection. We should optimize anti-TNF, it is better more than 10. If there is no response, assess drainage, repeat MRI. Ceton should be removed after 4 to 6 maintenance doses, okay, but till now there is conflict on the time of removal of ceton. If there is no healing despite mucosal healing in the rectum, we will shift to other types of treatment like hyperbaric oxygen, diversion, chronic ceton, experimental therapy, and so on. Suppose that the patient have small bowel obstruction. You face a patient with Crohn's disease and a small bowel obstruction. It is better as long as there is no ischemia in the bowel to avoid surgery. To avoid surgery because surgery is difficult and usually it is associated with enterocutaneous fistula. This is a nice algorithm published in the clinical gastroenterology. If we face a patient with intestinal obstruction, I will fix nasogastric compression, NGT, hydration, correction of the electrolytes. We will do CT and MRI and the inflammatory parameters, okay, to assess the degree of the inflammation from the start. If there is inflammation, and there is no symptoms of peritonitis or perforation, I will try to give treatment. Like corticosteroids or TDM-driven optimization of the therapy. Okay, if the patient did not respond to corticosteroid within 2 days or 3 days, we will shift to surgery. Okay, if there is no inflammation, from the start in the bowel, we will see if there is multiple strictures or circulatory structure of more than 5 centimeters. If there are features that can't be managed without surgery, we will do endoscopic balloon dilatation with endoscopy if it is feasible to the endoscope. But if the strictures are multiple or their size more than 5 centimeters or sharp angulation, abscesses, or there is dilatation more than 3.5 centimeters, surgery will be the rule. Again, I have a patient with a small bowel obstruction and he is known to have Crohn's disease. Number one, I will do CT and MRI to see if there is inflammation or not. If there is inflammation from the start, I will give 2 days trial of corticosteroids as long as there is no peritonitis or bowel ischemia. This is very important. If there is no inflammation of the start, see if the patient is fit for endoscopic therapy or surgical therapy. If the strictures are multiple or beyond the reach of the scope or more than 5 centimeters or the dilatation more than 3.5 centimeters, here surgery is the rule. If not, you may try endoscopic balloon dilation. If we have gastroduodenal Crohn's disease, it is mild, we can give PPI. If it is severe, like any Crohn's disease. Esophageal vaginal, we need from the start biological therapy. Enterovesical and enterovaginal, always anti-TNF plus surgery. Enterocutaneous, if it is low volume, it will need biological therapy. If it is high volume, surgery, biological therapy. We will come now to another issue. What is about the treatment of strictures? Stricture can be treated with steroids, immunomodulators, anti-TNF, surgical structuralplasty, endoscopic structuralplasty, surgical resection for the stricture, and new endoscopic techniques. When you find a stricture, you should do conjoint medical and surgical assessment. Okay? Strictures can be treated surgically or endoscopically. But there are criteria for endoscopic treatment and there are criteria for surgical treatment. Surgical treatment, you may repair the structure without excision of the intestine, and this is called structureplasty. Or you may excise the intestine, but it is not preferred. So the BCG said surgical structureplasty is better than resection, as we say always, especially if the structure is less than 10 centimeters. Okay? But proceed to resection when you have multiple small resections, okay, close to each other in a segment of the bowel, and the intestine looks healthy. The remainder of the intestine looks healthy. If the structure is less than 10 centimeters, we can do structural plasty. If they are multiple structures and close to each other, you can do resection. Okay? Echo said that structural plasty is safe option to treat small bowel structure, and it is preferred to resection of long segments of the bowel with potential reduction of the surgical recurrence rate. The BSG said that resection can be used if there is multiple small structures close to each other and the remainder of the intestine is good. Okay? Okay. When to do endoscopic dilation, endoscopic balloon dilation? The British guidelines said that you can do it if there is anastomotic structure, without sharp angulation and without nearby fistula. This is very important, or infection, because there is high risk of perforation. And also the structure, if it is present in the intestine, it should be less than 4 centimeters. Again, the structure, if you want to do endoscopic therapy, it should be within the reach of the scope or anastomotic. It should be less than 5 centimeters, not associated with fistula. So, endoscopic balloon dilatation, non-penetrating disease, and accessible iliac structure. Okay, but the British Society of Gastroenterology said that endoscopically accessible iliac structure, not anastomotic, is associated with higher incidence of complications. So it is preferred to do endoscopic balloon dilation for what? For anastomotic types. The gastrointestinal interventional IBD group said that the endoscopic balloon dilatation, it can be done for primary or anastomotic structure less than 5 centimeters, and it is more efficacious if the number of the structure is less than 4 and close proximity for each other. Avoid if there is deep ulceration, and if there is dilatation after the structure, avoid balloon dilatation. The ECHO said that the endoscopic balloon dilation or surgery are both suitable for treatment option for short structure of the terminal ileum. The gastrointestinal interventional group said, again, the structure should be less than 4 centimeters. If it is multiple structures, it should be less than 4 in number and in close proximity to each other. Okay? Avoid if there is deep ulceration, and avoid if there is pre-stenotic luminal dilation. If there is concurrent fistula or abscess, never do, because there is high risk of perforation. Avoid the old techniques of injection of steroids or anti-TNF. They have no value. There are new techniques for managing the structures endoscopically, like electro-incision. But they said that if you want to do endoscopic electro-incision, it must be in special centers. And it should be used as a second-line therapy. Electroincision, it can be used particularly for anorectal strictures. Electroincision can be made using various knives and endoscopic retrograde cholangiography power setting اللي هو الاندوكات mode. You may use fully covered stents for strictures in selected patients and in which endoscopic electroincision is not successful. يبقى the third line for therapy symptoms. If we have intra-abdominal abscess, you should do giving antibiotics plus radiological intervention, and if there is failure, we should proceed to surgery. Never give anti-TNF with infection. This is abdominal abscess. If we find it, if it is more than 3 centimeters, you should do percutaneous drainage, okay, and give antibiotics. If it is less than 3 centimeters from the start, you can give antibiotics and check the response. If there is bad response in follow-up, I will do drainage and so on. Pre-surgical assessment. Suppose now that you have a person with Crohn's disease and he will undergo any abdominal surgery. What should we do? For resection, structural, plastic, whatever. Number one, you should assess the nutritional status before the operation, especially if it is elective. Avoid steroids before operation because they increase the risk of infection. If steroids are mandatory to use due to other disease, use the lowest effective dose. But if you continue to use steroids, you should do a temporary stoma to avoid infections. Okay? Anti-TNF, vedolizumab, and ustekinumab are safe drugs, and always try to control sepsis before. After operation, we always afraid of the recurrence of Crohn's disease. We should do assessment for the symptomatic recurrence after resection by ileocolonoscopy. We can use also fecal calprotectin. We can do CT enterography and so on. When we should do assessment for recurrence, it should be done 6 months post-operation. If the patient underwent ileal resection and he is complaining of diarrhea, we may use cholestyramine. And if there are symptoms and you did CT enterography and you didn't find a cause related to Crohn's disease, search for other cause. Stopping smoking is mandatory to prevent recurrence. Okay. We should classify the patient regarding recurrence. Is the patient high risk or low risk? Okay, we previously said the criteria. If the patient has high risk for recurrence of resection, we should give him from the start anti-TNF plus cyclopurines, never use FISA. If the patient has low risk of recurrence, we will do what is called endoscopic guided pharmacological treatment. Do endoscopy after 6 months to see if there is recurrence or not. Recurrence, we will give anti-TNF. No recurrence, don't give anything. Okay? But if the patient is high risk from the start, we should begin early pharmacological therapy. Early pharmacological therapy. Time of follow-up. The pharmacological prophylaxis, the AGA, suggests post-operative endoscopic monitoring after 6 months. Not receiving pharmacological prophylaxis, the AGA recommends post-operative monitoring after 6 to 12 months after surgical resection over no monitoring. If the patient is low risk, do endoscopy to assess the recurrence of disease. Recurrence, give treatment. No recurrence, don't. If the patient is high risk from the start, give early pharmacological prophylaxis from the start. Better. Always stop smoking. Always stop smoking. Should we give antibiotics? Yes. They found that giving antibiotics, especially in the low-risk patient, for 3 to 12 months after surgery, it decreases the recurrence. But if there is high incidence of recurrence, we should give from the start anti-TNF plus azathioprine, but when to start? Within 4 weeks of surgery. Within 4 weeks of surgery. Okay, this is a nice algorithm from the British Society. We will give this before discharge for ileocholic resection. We will give him antibiotics for 3 months. Okay, and we will see the patient is a smoker or not. If he is a smoker, he must stop smoking. Refer to him to a center to help him to stop it. If he is not a smoker, look for the risks for recurrence. If there is no risk, I will prefer the endoscopic. We will do endoscopy to see if there is recurrence or not. If there is risk from the start, we will begin anti-TNF, of course, and we will do endoscopy. You will use Rutgeerts score at 6 months to see if it is I1 or I0 or I1 there is remission. And if there is no remission, we will continue the treatment, of course. Escalate the immunomodulator therapy one step, thiopurines and anti-TNF, then high dose anti-TNF. And the risk factors for the recurrence are here. There are some questions we need to answer. Uh, should we use the therapeutic drug monitoring? Yes, there are two types for the therapeutic drug monitoring. We measure the trough level of the drugs. There is proactive or reactive. Proactive means before loss of response. You predict the loss of response before its occurrence. Okay, I begin the therapy and I will check the drug level to monitor it and to optimize it to avoid loss of the response to the drug. Okay, most guidelines are said that it is debatable and the benefit is not so much. Okay, it is better to do reactive. Reactive means that when you lose the response for the drug, just measure the therapeutic drug level to see what is the cause. Okay, and of course at the same time we measure anti-drug antibodies EDA. This graph, this table is very important when to measure and what is the trough level. Infliximab, it can be done at week 2 or 6, 14 or 4 for adalimumab. These are the levels. Okay, so I will have reactive. Now there is loss of the response. I will measure the trough level. If the trough level is low, okay, check for the antibody ADA. If there is high antibody titer, no drug will be beneficial. I should switch to another group. If the antibody is low or negative, I should intensify the drug or decrease the duration between the drug. But suppose that this is also the same. This is from the British Society. BCG said, I have now active disease. I now have active disease. So this is reactive and this is proactive. Okay, this is reactive. I have now active disease. I will measure the drug level. Okay, it is optimal. Oh, you lost the response. Switch to other group. If it is not optimal, I will see the antibodies. If the antibody is high, I will switch in or out of the class. Switch in or out means in some centers, if you have resistance for infliximab, switch to adalimumab, but it is not preferred now. Switch to other group like Vido or ustekinumab. And if the patient was not an immunomodulator, add immunomodulator. If the antibodies is low or intermediate, I should intensify the therapy and optimize the immunomodulator for measuring TPMT level. Suppose now that you don't have active disease, okay, and you did measure for the drug. You found that the drug level is optimal and there is no active disease, so I will continue the treatment. Okay? If the drug level is very high, try to decrease the dose. Okay? But if I have now no active disease, but I found also that the drug level is suboptimal or undetectable. If it is suboptimal, do antibody test. If it is low, monitor for loss of response. If it is intermediate, consider adding immunomodulator. If the antibody titer is high, okay, consider adding or optimizing immunomodulator and consider withdrawing or switching to another alternative. If the drug level is undetectable, okay, if the patient achieved the remission, we may consider withdrawal. We may consider withdrawal. Always you will be asked by your patient, could I stop azathioprine? Could I stop infliximab? Or I will take this drug for life. This was discussed in a nice paper in the clinical gastroenterology and hepatology. They found that these drugs, when stopped, there is high incidence of relapse, especially with the presence of these risk factors. For example, for anti-TNF, if the patient has low hemoglobin, high white blood cell, endoscopic activity, elevated CRP or fecal calprotectin, wall thickening on MRE, smoking, young age, short duration of treatment, okay, prior surgery, prior failure of immunomodulator therapy, there will be high incidence of relapse and stopping anti-TNF should not be recommended. The guidelines did not recommend, the ECHO is the only one who mentioned this point and did not say a clear recommendation. In this algorithm, I will measure the disease activity by fecal calprotectin, by colonoscopy, by CRE. Okay. Now I have inactive disease, so I want to withdraw my drug. I will ask which type of therapy I am giving now. If you give monotherapy, okay, by cyburines or anti-TNF alone, or I am giving combo therapy, okay. If I have high risk group like young age, TI, location, perianal disease, and so on, or I have no risk factors. If you don't have any risk factor, you may de-escalate the therapy. You may de-escalate the therapy. If I have these risk factors, I will not stop the therapy. Right. What will you do after escalation? Because there is high incidence of relapse. Okay. I will assess the disease activity by investigation, radiological or laboratory. Okay. If the investigation began to rise, I will return again to therapy. But if they normal, I will just follow up the patient. Thank you very much. I know it was a long lecture, but it needed to be taken in one shot, as they say. We finish with this دعاء, with this prayer. اللهم إني أسألك من الخير كله عاجله وآجله ما علمت منه وما لم أعلم وأعوذ بك من الشر كله عاجله وآجله ما علمت منه وما لم أعلم اللهم إني أسألك الجنة وما قرب إليها من قول أو عمل وأعوذ بك من النار وما قرب إليها من قول أو عمل اللهم إني أسألك مما سألك منه محمد صلى الله عليه وسلم وأعوذ بك مما استعاذ منه محمد صلى الله عليه وسلم اللهم ما قضيت لي من قضاء فاجعله عاقبته لي رشدا. Thank you.